talk today is going to be on mood disorders. I'm Dr. John Mauk. I graduated from Western University in Pomona, and then I also have a master's degree in theology. And this talk is going to be on mood disorders, like I said, and it's going to be particularly geared toward people that are not in the mental health profession. My hope is that you get a general idea of how important mood disorders are. What is a mood disorder, of course, just to be able to define that. And then in addition, to learn a little bit more about mental health, to reduce stigma in mental health, and then to learn about some of the practical things and the ways that mood disorders can be treated, both non-medication wise and then medication wise. So first, what is mood? The most simple thing is it's just how you feel. So happy, sad, anxious, okay. Each of these are moods. So we're really talking about mood a lot just kind of in our day-to-day speech. You can either feel really down, which we would call that depressed, or really up, which we would call that manic. You can also feel kind of down, dysthymic, or kind of up, hypomanic. You can even feel up or down at the same time. And the reason why I put this picture here is not just because it relates to mirth and misery and Greek plays, which are always really awesome, but because if you're going to be taking the post test for this talk, then you should pay attention to the bolded parts on the slides and the slides that have the mirth and misery faces in the bottom right hand corner. So just a heads up there, pay particular attention to that. Some people understand what I just said based on the fact that you are good at auditory learning, but some of us are not as good at auditory learning. We need more pictures. So what is manic? Well, it's just, and this is from Stahl's psychopharmacologic textbook. This is mania. It's feeling really good, rainbows and music and sunshine. I would have included butterflies. Feeling down or depressed, this is down. This is the thunderstorm, the sad music, like Fast Car, a great song. And hypomanic, just a little bit up. And of course, mixed. And we sometimes forget this. We think that we're supposed to be either happy or sad, that this is binary, that that you can't have both at once. But you can definitely have both happiness and not just happiness. With mania, we're talking about unstoppable happiness, you could say, and then unstoppable sadness at the same time. This is called psychological ambivalence. And, the fact that I can be angry with someone and love them at the same time, this is something I think we can all understand. And the same is true with kind of feeling manic and also feeling depressed at the same time. I'm going to move my face here because now I'm kind of blocking the screen. I'll come back if I'm doing exaggerated hand motions and things like that. So what is a mood disorder? A mood disorder is impairment in your social and occupational functioning as a result of your mood. So just because you feel really good or you feel really bad doesn't mean that you have a mood disorder. You actually have to have some change in your life. So you feel so good that you're like, I'm just going to quit my job and I'm going to start saving all the children in the world. I'm going to start an orphanage, but you don't really have the tools or wherewithal to do that or any kind of training. Or you just say, I'm so depressed right now, I'm just not going to get out of bed. And then anything, of course, in between that. Those are kind of extreme examples, but anything that would be between those would also count as a mood disorder. It's not explained by a medical condition. So, some people that have low thyroid, they aren't able to get out of bed, or they feel really amped up. This is not that. Anything that's due to a medical disorder is not a mood disorder. That's just low thyroid or high thyroid. And it's not better explained by another psychiatric diagnosis, because other things can affect your mood. Like, let's say I had PTSD. My mood would be affected, and maybe I'd feel down, but that's due to my PTSD. It wouldn't be due to depression per se. What are we going to cover in our talk right now? Well, I want to cover the two major types of mood disorders, and those are depression and bipolar disorder. I just want you to be aware of that underneath the umbrella of depression is major depressive disorder, which is MDD, seasonal affective disorder, which is SAD, dysthymia, which is just I'm kind of depressed, postpartum depression, and then grief. So all of these are DSM-5 mood disorders. DSM-5 is the big 1,000+ page book on all the psychiatric illnesses in existence, and even hypothetical psychiatric conditions. But the biggest that we really see are major depressive disorder and then dysthymia. We see other ones, but these are the ones that I want you to know of. And then in bipolar disorder, we have three types: bipolar 1, bipolar 2, and then cyclothymic. But we're just going to cover bipolar 1 and bipolar 2 today. Um, the next bullet point is DDX of mood disorders. That stands for differential diagnosis. So other than a mood disorder, what could this be? And then treatments of depression and then bipolar disorder. And what we're really going to emphasize is medications and ECT, electroconvulsive therapy, which we as a society have a lot of baggage with, and we're going to talk about some of the evidence for and against it. And what I want you to know is just the bolded and underlined parts here. So starting right off, we're going to cover depression. Here's a cute, sad cloud of someone that is depressed. Depression, of course, does not look like this, but I also don't want you to feel overwhelmingly sad while you're watching this. So here's an interesting question, and my thoughts on this are changing. I don't really have an answer to this question, but why do the depression genes stay in the gene pool? Is there any advantage to have a propensity for depression? And there has been some study on this, and basically it's interesting. And I'll let you just think for a second on this while I just babble. So, why does this stay in the gene pool, these depressed genes? Could there possibly be any help in this? And really, the answer is that depressed people, at least mildly depressed, may actually see the world a little more true to what it is. There's actually a lot of badness in this world. And so people that are in touch with that badness and kind of handling that badness appropriately, probably when you ask them, don't say, how are you doing? I'm doing great. This world is such a magical place. And they really see the world kind of probably for what it is. A place filled with wars, a place filled with disease, a place filled with hatred. And so I would think that could be the answer to this. I think also dispositionally, introverts are just a little more prone to depression, while extroverts are not as prone, because introverts kind of see the world a little clearer, right? You're not like Elon Musk trying to change the world, building tunnels under the ground, right? They're not interested in those things. And so in a way, this kind of comes down to kind of who we are as people too. Here's an example patient, let's say. An 85-year-old white male with no prior psychiatric history presents to your hospital after running naked through the streets. His son brought him in and states that his father had periods of immobility and has been very paranoid. His son reports his father's mood has been very depressed for the last year. His son also reports that his grandmother, the patient's mother, became very depressed around the same age and required ECT therapy, which was effective in alleviating her depression. So this was a real patient that I saw. And this could be an example of a depressed patient. Now we'd have to rule out medical things first. And we'll come back to this patient and how we'll treat them. But sometimes what I want to point out is that depression can become so severe that you don't move, you don't eat, you think that maybe demons are after you. And this can go on for quite some time. And it's very important to treat this because this is actually killing this person's brain. They're losing about 1-2% of their brain every year, but they're in this state, and it's very neurotoxic. So this is something we want to treat. And we'll talk about treatment of this in a bit. Why is this important, though? Why is it important to treat this? Not just because of the brain injury? Well, 1% of the population is going to die by suicide. Now, not all of this suicide is due to depression. You can commit suicide for other reasons other than being depressed, but the vast majority of it is due to depression. Depression is also just prevalence-wise, 20% of chronic medical illness. So, like if I have diabetes or hypertension, and you take all those people together, 20% of them are gonna be depressed. So it's very common, especially in people with a lot of medical conditions. It's the second most common chronic medical illness after hypertension. So there's just going to be a lot of people in this world that at some point in their life are going to have hypertension. There's going to be a lot of people in this world that at some point in their life are going to have depression. And we really lose a lot as a society. The cost of depression is about $4,000 annually for people that are depressed, $2,300 annually if you don't have depression, higher rates of death in depression. Um, if you have no other risk factors, your rate of death is still doubled. It's the biggest predictor of death, actually, so when depression is running with other medical illnesses, it can be the most biggest cause of death. So after a heart attack, the biggest risk of death at 6 months isn't hypertension, it isn't how your vessels look, it's actually depression. And if you're depressed, you have 2 to 4 times higher mortality. It also leads to increased risks of falls in the elderly. So if and falls in the elderly are what's going to kill them, and so depression is going to cause that as well. And all these statistics that I just kind of rattled off are from a consult and liaison book on psychiatry um, called Mass General, the Mass General Hospitalist Handbook on Psychiatry. So if you're ever interested, you can turn there. So that's why depression is important. I mean, anywhere between 5 and 17% of us are going to experience it in our lifetimes. And so that means one and at least 5 out of every 100 people you know will experience depression, and at most close to 20 in 100 people, or 1 in 5 people that you know are going to experience depression. And so that's a lot of people. This is going to affect people that you know and people that you love, and it might even affect you yourself. What makes us depressed then? There's been a long-term debate. Is it nature? Is it nurture? So nature would be genes. It's just these genes that I've been given. I couldn't avoid it. I was always going to be depressed. And or is it nurture? You know, it's just these darn parents that I have. It's the fact that I didn't have parents. It's the fact that I grew up in a broken family. Well, it's a little bit of both is what we find. So, you know, the fact is there are people that come from broken families that are never depressed, and there's people that come from amazing families that are horribly depressed. And we really know this at the end of the day from twin studies. So if you take twins and one twin is and they're identical twins, and one twin is depressed, the other twin about 70% of the time, maybe up to 90% of the time, will be depressed. So that's pretty genetically related, actually. Where if they're fraternal twins, right, the non-identical twins, it's 16 to 35% of the time the other twin will be depressed when one is depressed. So these studies are good because identical twins have the same genetic material, while fraternal twins don't, but fraternal twins have the same environment. So it kind of tells you how much environmentally it's related. But it is both. But it looks like with at least depression, the preponderance is in terms of um, what the genes behind it, and that's why I put this wine glass here, because the type of grape is going to make how good the wine is. But at the end of the day, there's a lot of things that go into wine outside of the grape, like sugars added and things like that. that are going to make the wine a loose analogy at best. Maybe I just wanted to put a wine glass in here. I don't know. What are the types of depression? We have major depressive disorder, as we already said, dysthymia, which is I'm just feeling really bad, seasonal affective, feeling bad, but not really bad. Dysthymia is I'm feeling bad just a little bit all the time. Seasonal affective disorder, um, it's winter right now, there's no sunlight, so I just feel bad. Or I live in Seattle, um, and so I just feel bad all the time. Postpartum depression, I just had a baby and now I'm depressed because of the drop in my hormones. Grief, I just lost someone, and so I just feel down. Grief can turn into major depression if it starts impairing functioning. That's the difference. And then adjustment disorder is I have a new medical diagnosis, like a cancer diagnosis, and now I feel really down. If it begins affecting the functioning, then it could be more of a major depressive disorder. And if it doesn't go away, of course, it's not adjustment disorder if it stays around. It's just an adjustment disorder. If you get the cancer diagnosis, you feel down and then it goes away, which is what happens for the majority of people with that diagnosis. Two ways to think about psychiatric diagnoses. Now, this is changing for me. I think the goal is, as we all learn, is to get more models about how things work. Um, Having a model, one of the advantages is you can think of things in a different way to get a more accurate diagnosis. Um, it's not very good for research. Your model is your model. Like when we do research, we have to use the DSM-5. We can't use really anything but the DSM-5, or we have to use a scale. Um, the DSM-5, which is a great model, it's good for research. It's very sensitive. It's not very specific. It's based on symptoms alone. Um, the DSM-5 diagnosis of major depressive disorder. So we should do this first because this is the gold standard. You need 5 or more symptoms lasting 2 weeks with impairment in functioning. How do I know which symptoms I have? Well, you can remember it with the mnemonic SIG-E CAPS. So I want you to remember this. This is sleep, interest, guilt, energy, concentration, appetite, psychomotor changes, and suicidal thoughts. And it's not that I want you to know all the specifics. I just want you to know that the SIG-E CAPS mnemonic is connected with depression. And you need 5 of these. So if you could have SIGECA, that would be 5. You could have GECAP, GCAP, that's 5, right? So you just need 5 lasting for 2 weeks, and then that impairs functioning. And you can already kind of see here, maybe well, let's think about this for a second and see why this might be problematic. So changes in sleep. This is kind of like, Doc, I'm sleeping horrible. Well, how do I know what really horrible is, right? Is a bad sleep 7 hours? Is a bad 6 hours? Is a bad 6.5 hours? Is it waking up for 10 minutes at a time during the night? Is it waking up for 30 minutes at a time during the night? Is it waking up once at the night for 30 minutes or twice at night for 30 minutes? So it's really hard to kind of quantify what bad sleep is. And so that's why, even though we're trying to quantify depression here and we're trying to say this person's definitely depressed because they have problems with their sleep, or this person's definitely depressed because they have problems with their interest or they feel guilty about everything. It's like, it's hard to say what pathological sleep really is, and it's hard to say what pathological loss of interest is and pathological guilt is. Usually the kind of fallback is impairment in functioning. But there's times when I'm, not depressed and I just have bad sleep and I have changes in my interests and I feel guilty, like when I start grad school, right? So then is everyone that starts grad school depressed, or is everyone that has a newborn at home depressed because they have a change in their sleep and a change in their interests? All I'm doing is watching a baby and I feel guilty. This baby cries and I have less energy. After I put the baby down, I just sit there and mindlessly watch TV and I can't concentrate on anything. And oh, I have a baby. I'm not eating at all. and I feel agitated all the time. I'm just pacing the house with this baby, or when I put the baby down, I'm just sitting there. I'm not moving at all. And sometimes I think, yeah, life would be better off. Life would be kind of nice without a baby. Maybe it'd be nice if that baby wasn't here, right? And so there's clear ways where like you're definitely depressed, but then at the same time, an argument can be made. It's kind of hard to know when this changes, and so that's why I say there's other models that we could have aside from the DSM, because even this isn't written in stone. So that's my diatribe there. The DSM diagnosis for dysthymia. This is just for your reference. Depressed most days for at least 2 years, hopeless, SGECA, sleep, guilt, energy, concentration, and appetite. So it's just basically a low mood with some of these other changes without any loss of functioning. That's what dysthymia is. What about models of depression? So other ways to view depression that are outside the DSM. Some of these are really cool. And I just kind of like nerding out about these. This right here is a brain scan. This is a an fMRI. So if you took your brain regions and you looked at a special MRI, a special magnet that then looks at how water is moving through the axons. That's how a functional MRI works due to water movement. Then you can actually look at the specific neurons themselves and how active they are. Then it's color coded. I'm actually colorblind, so I'm not even going to attempt to tell you what colors these are. You know them better than I do. But essentially, some of these regions will be more active during tasks and some of them will be less active. And you can even show people a monitor while they're in the machine and they can say, wow, look, this region's lighting up. If you show them a picture, then the back of the brain should light up because that's where your picture regions are. If you show them a sound, then this region should light up. And so it can do a lot of really cool things. So we'll go over both imaging and kind of medication, and then we'll look at a brief kind of psychological model for depression, typical, let's say, versus atypical. So one model for depression is that it's a change in your neurotransmitters. And it's actually really interesting how this came about. So what they did was they took people that had committed suicide and they like let's say someone jumped off a bridge and they killed themselves. During autopsy, they took out the fluid in their spine, which is called the cerebral spinal fluid, and that fluid has chemicals in it that your body produces, and the chemicals in your spinal fluid are the same concentration as the chemicals in your brain. So essentially, it's an indirect way of finding out what's going on with the chemicals in your brain. And what they found was there was decreased levels in your spinal fluid of a couple chemicals that are normal in people that die through ways other than our suicide. And so they found, like, if you died of a heart attack and you weren't depressed, then your serotonin, your norepinephrine, and your dopamine would be normal. That's what 5-HT-NE and DA are: serotonin, norepinephrine, and dopamine. But in people that were depressed, these serotonin and norepinephrine and dopamine were low. So the original hypothesis was that, what we need to do, we need to increase serotonin, norepinephrine, and dopamine, and then people will get better. But the weird thing is if I give a medication that increases these, they don't get better immediately. It actually takes a couple weeks, maybe a month, maybe sometimes even a month and a half. So the question is, wait, if I am increasing if I'm increasing the dopamine immediately, day one that I give you the medication, because that's what the medication does, why does it take a month to make you less depressed? And so and there's a bunch of other theories on this, but one of the theories on it is that it is changing the receptor firing rate. And so it's not just that it's affecting the neurotransmitter, it's not just that it's affecting the dopamine, it's affecting the dopamine receptor. And it's actually the fact that the receptors are a little wonky, a little weird, that's what's causing the depression, not the chemical itself. So then what the medications are doing, like the selective serotonin reuptake inhibitors or SSRIs, the medications that increase serotonin, are going to correct this by increasing the serotonin, which is then going to change the firing rate of the receptors and the number of receptors. This is all alphabet soup. I think a picture's worth 1,000 words. So let's look at a picture of this. So here, this is from Stahl's Essential Guide to Psychopharmacology. So here's a normal brain with no depression. And we see our receptors, 1, 2, 3, one dopamine receptor, let's say, one serotonin receptor, and one norepinephrine receptor. And then the dopamine is these, oh, what is this shape? This is a pentagon? I wish you were here so you could tell me. And then this is a little person, little yellow person, and then these are little triangles, right, as the neurotransmitters. So normal nerves with no depression have just a normal number of receptors and then a normal number of neurotransmitters. This is actually really accurate because all these nerves are produced, all these neurotransmitters are produced in the brainstem, and then they go up to like the cortex or other regions in the brain. This is a pretty good drawing. So what happens in depression? Well, in depression, maybe the nerves just say, I give up. I'm not going to release any neurotransmitter. So then what happens to the receptors is the receptors go, whoa, I'm not seeing any dopamine, norepinephrine, and serotonin. I know what I'll do. I'll make more receptors. That's what your brain, let's say, says. Because everything wants to stay constant, right? The brain wants to keep firing at the same rate. So I know what I'll do. I'll look for dopamine. I'll just look for it. But dopamine's not really there a lot of the time. So what will happen is the time when dopamine is there, it'll hit the receptors, and the receptors will go, oh my goodness, there's dopamine, and it'll fire, 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 fire like crazy, right? But when there's no dopamine, it'll be just totally quiet. So what you then get is you get these not a steady kind of constant firing like click. You can actually hear neurons talking. There's like voltmeters and stuff, and they'll just click. So click, click, click. So maybe a normal brain sounds click, 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 and then a depressed brain would sound click, 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 and then silence. And so you're getting these rapid firings then with no firings at all. Here's another way of kind of looking at it. Um, this is so hopefully this, well, let me back up. Hopefully this makes more sense of how we treat depression and what depression is due to. And so essentially what we're doing when we treat depression is we're adding more of the triangles or more of the triangles and these yellow molecules like norepinephrine or more dopamine. And then initially your brain's actually going to feel kind of worse, right? Because then all this dopamine is causing all of these receptors to fire like crazy. But then over time, the receptors will go down back to normal, and you'll have a situation more like this. So that's one of the thoughts on how maybe we can treat depression. Here's another interesting way that we can treat depression, or that just depression exists. So some people doubt that depression, is this really a thing? And some of these imaging and neurotransmitter concepts kind of help point to the fact that no, this really is a thing, that depression really does exist. So here's what a normal person looks like, and you tell them, hey, let's solve this problem. And this is their prefrontal cortex, the problem-solving area of the brain. And it activates, and they're like, oh, I can solve this problem. 3 plus 3, what is that? That's 6, I got it. Or more complicated problems, right? So it's lighting up. And this is with a kind of like an fMRI here. We're just showing what's lighting up. And these are scans that have really been done. And then here is some of their emotional centers. This is ventral medial prefrontal cortex and the amygdala. So these are the emotional areas of your brain. So 3 plus 3, oh, I'm thinking about it, I'm thinking about it. There's not a lot of emotional attachment to that, right? They're just numbers. But now look at the depressed brain. 3 plus 3, I just don't know. And then what are their emotional centers saying? They're on fire. I'm a failure. I don't even know what 3 plus 3 is. Oh, this is horrible. So that's essentially what's happening. And actually, it's a little more nuanced even than that. Hyperactive here in depression, just resting. And really what it is it's hyperactive, not to happy signals, but to sad signals. So this is why when you're depressed, you really don't want to listen to sad music, because if you're in a not depressed stage and you're listening to sad music, you're like, oh, this is sad. And you can process that because the front of your brain's working, and these middle brains are working okay. But then when you're depressed and you listen to a sad song, you're like, this is the saddest song I have ever listened to in the entire world. I want to listen to it more. It gets me. So you really don't want to do that, because your brain is exquisite when you're depressed. It's exquisitely attuned to signals that are also depressed, and it's just going to make your depression worse. And we can literally see that on brain scans. Uh, Here's a model then. We've gone over a couple, pathophysiology. We've gone over the receptors. We've gone over the brain images. Here's just some psychological models to think about depression. For typical depression, the onset is in the 20s or 50s. Mostly this is for men. And that's because men young in life are kind of lame members of society. Like, I don't have a job, I don't make any money. What am I doing in this world? So that's why depression typically starts in men in their 20s. In their 50s, men, again, it's kind of just related to the job in normal. Oh, I'm a loser. I just quit my job. My whole life was my work. What am I going to do now? I'm sailing around the world, but I have no meaning in this. So that's why for men it happens at that. And you can kind of imagine just kind of the grumpy old man that you think is just grumpy, but actually he's depressed. And that's why irritability is one of the most important um, symptoms to screen for, because a lot of the times this will just present as a very angsty teen, a very angsty young adult, or just a grumpy old man. This grumpy old man is probably depressed, and so that's just something to keep in mind. And that's why I want you to remember it. And then neurovegetative symptoms like them not wanting to eat or drink or losing interest in things or just kind of lounging around the house doing nothing. Um, this is kind of the typical depression. In women, I just talked a lot about men. In women, it's usually actually hormonally related, the typical depression. So the biggest uh, time of depression is near menopause. And that happens because estrogen helps you feel a little better. Progesterone helps you feel a little better. And during menopause, both those hormones just plummet. So you're not feeling good anymore. In men, testosterone actually makes us feel, it even works a little better for the mood than estrogen or progesterone. And so we produce testosterone really throughout our lives. And so we're not as prone to these hormonal swings. It's more related to kind of work and life and things like that. And interestingly, it's also, genetically related, of course. And if 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 your mother, let's say, became horribly depressed at age 50, there is a higher likelihood that, of course, you're going to be depressed at that time. For this typical depression, they typically don't seek. They're just like, I just have a case of the blues, or I'm just grumpy, or these people are just really pissing me off, and it's their fault. So they don't really see it as something that they need to take care of. And then suicide attempts are often premeditated and lethal. There's another type of depression, we could call it atypical. This is people that are kind of chronically suicidal, beginning in teen years. They'll cut or hurt themselves. This strong genetic component, of course, to this as well. numerous suicide attempts. And then these suicide attempts are often impulsive um, and non-lethal. So then the goal just becomes to, over time, this will typically get better. And so, um, yeah, it'll just get better over time. Other causes of depression, just to remind you again that um, half of people with depression actually have another underlying cause, and it could be developmental delay. Um, they're just not able to do as well in life because their native IQ is a little less than everyone's, and they realize that. Or obstructive sleep apnea, they're not breathing at night. And when you don't breathe at night, that tends to make the brain hurt and feel depressed. Or they're on drugs. I use meth, and I don't personally, but I've heard of people that do. They use meth, and their brain runs out of dopamine, and now they feel depressed because the meth just burns up all the dopamine. Medications, of course, can do this. Thyroid problems, strokes, traumatic brain injuries, you hit your head, dementia, delirium, anemia. I have low red blood cells, chronic pain. I'm always in pain. I can't get rid of the pain. That's going to make a lot of people depressed if they stay in pain, or just chronic illnesses. I just can't shake my diabetes. I just can't shake my hypertension. And that's really common for patients with diabetes and hypertension. I think it was like over after 8 years of diabetes, over 50% of patients are depressed. So just having these conditions for a long time will make people depressed. So that concludes kind of our first hour of lecture on depression. The next hour of lecture is going to be on mania. So hopefully there's not too many questions. I'm used to talking to people about this. You're a person, I'm talking to you, but we can't interact. Usually I would stop for questions, but I guess I can't now. Mania, the reason why I put this slide is it's really common for people with mania to have delusions of grandeur and religious delusions. On the inpatient unit, it kind of cracks me up. There's all these people wandering around with their Bibles. Um, and typically those are the manic patients, and they're like, I got a word from Jesus. And it's always fun when they talk to each other. I got a word from Jesus, and the other manic patient says, no kidding, me too. And then they're talking excitedly to each other about how spiritual they are, and sometimes they're kind of outcompeted, and that's when you kind of need to separate them because the irritability component is there too, and now they're like, no, I'm Jesus, no, and that's when it gets a little more concerning. But a lot of the times they're just happy and they've had a revelation that they with everyone in the world, and that's why they're quitting their jobs, and they're going to save all the children in the world with their new revelation, and that's treatable. So here's another question. We started kind of with the question of depression. Why do these genes hang around? Like, is there any advantage to that? What about mania? Why would it be good to have an elevated mood, to feel like you could do anything, to feel unstoppable, to not be in touch with the way the world works at all, right? Well, sometimes you need a little bit of Elon Musk, so to speak, right? You need to think, you know what I'm going to do? I'm going to create electric trucks, and I'm going to throw a bowling ball at it. Oh, the bowling ball just broke the window. Well, it's going to be fixed. It's going to be fixed. We're going to roll out the truck. It's going to be perfect. It's called a cyber truck, right? And so if to be kind of more connected to reality than everyone else, doesn't it's not going to sell cyber trucks. You have to kind of have an unstoppable. And this isn't to say that Elon Musk is manic. He's not. But he's probably hypomanic at times. He's probably kind of up there and thinking, and I cannot diagnose him. Let me do the disclaimer. I cannot diagnose him. I have not evaluated Elon Musk, and if I did, I couldn't speak about it. So technically, I cannot diagnose him at all. But I'm just saying that's the kind of person that you can connect this idea to. Here's an example of a real-world manic patient. He's a 31-year-old male who presents to the hospital because I went on a spirit quest to save all the children in the world. He was found wandering around the streets in San Diego, suicidal. He had lost his car prior to going into Mexico and does not remember how he got back to the States. He has been averaging 2 hours of sleep for the past month. He wants to quit his job to continue his spirit quests and wants to leave the hospital. These patients always want to leave the hospital because they always have something big to do that you're keeping them from doing. Whatever that thing is, they're about to change the world. And when you see him, he appears euphoric. So he's kind of lost everything, right? He doesn't know where any of his stuff is. And he thinks he's accomplishing his mission, even though he doesn't have the ability to. And then euphoric means he just feels incredible. So even though he doesn't really have any reason to at this point, because his life is kind of falling apart, right? I wouldn't feel amazing if I had just lost all my stuff, my car, I just quit my job and I was found by the police and now I'm in a psychiatric hospital. That wouldn't be the best day of my life. But for him, this is just one stop in saving all the children in the world, and it's only going to give him more guidance. So this is very typically extreme, and this is bipolar 1. There is a very much less extreme form called bipolar 2. And bipolar 1, this is the DSM-5 diagnosis, the textbook definition. 3 or more symptoms of inflated mood. So it's marked by this mood of I feel amazing. 4 if they're only irritable. So you need another symptom if they're irritable. And the mnemonic to remember it is called dig fast. And dig fast stands for distractible, irritable, irresponsible, grandiose, flight of ideas, increased activity, decreased need for sleep, and then talkative. So, I mean, there are just some people that are very high strung and they always, I'm sure you could think of people in your own lives that kind of always act like this. But they're not manic because they don't have impairment of functioning. I mean, you can see how much this impaired this young gentleman's functioning on the last slide. He's losing his car, he's losing his job. Um, he's not Elon Musk, right? And it must go on for more than a week. So if you're doing this for 6 days, even if it's impairing your functioning, technically, some people might still call it bipolar 1, but technically, if this is going on for 6 days, this is not mania. It's only 7 days, or bipolar 1. It's only 7 days. If 7 days or more, then it's bipolar 1. Bipolar 2 is less time. It must go on for 4 days. So really, it's that 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 4 versus 7 days that differentiates bipolar 1 from bipolar 2 because both share the dig fast criteria, and both have either 3 or 4, 3 criteria if it's an inflated mood, 4 criteria if the mood is only irritable. How does mania come about? So we have a couple models, pathophysiology of mania. So now let me back up. So bipolar 1 is a diagnosis, mania is a symptom. So for example, cough is a symptom, COVID is a diagnosis, right? So we know that you can have a cough and not have COVID. You can have mania and not have bipolar 1. That's what I'm saying. So, but mania is defined by all the dig fast criteria. So mania is all the dig fast criteria. So really when we're talking about pathophysiology, we're talking about the pathophysiology of maybe bipolar 1. And then how do we separate bipolar 1 mania versus mania that's caused to like medical conditions or just feeling amazing or things like that? So we'll talk a little bit about that as well. First of all, let's go to the brain scans. These are, again, kind of interesting. Both of these are, again, are from Stahl's Introduction to Psychopharmacology. This is the orbital frontal cortex. And the purpose of the orbital frontal cortex is to say, that's a really bad idea. So let's say I get an impulse, and this happens to all of us. I see a cliff, and I'm a teenager, and I think, oh my goodness, that is a big cliff. It goes into the water. You know what would be fun? It would be fun if I jumped off that cliff. And then if I'm a teenager, unfortunately, this brain region is developing. So a normal teenager, it might not light up very much, but hopefully, you get later in the teens and your peer group isn't there. You'll say, oh, wait, that's a bad idea. It's like 100 feet high. And 100 feet high, that almost looks like I'm going to hit the water like concrete. So I'm not going to do that. And so really the purpose of the orbital frontal cortex, I think of it as like a no zone. And you say, no, that's a bad idea. And, if you have a bigger orbital frontal cortex, you have a bigger no zone, you're going to say no to more things that seem dangerous because you're going to be able to process that better. Now, look what happens with mania. I'm going to save all the children in the world. I'm going to jump off this cliff because I can and hit the water. Okay, I'll do it because there is no stop sign telling me not to do it. And so, in a nutshell, in terms of brain regions, that's kind of what's happening with mania or bipolar 1. Here's another model for bipolar 1. Some of this is synthesized from a bunch of different sources. One would be like Kaplan and Sadok's synopsis of psychiatry. But this is not, so even though the DSM says mania has to last 7 days, so I've had some patients that are like, yes, I felt it for a whole week. But really, mania will last a lot longer than that. Untreated, it'll last like 6 months, and it can last, and that's average, so it could really last up to a year. Of course, it could, last less than that, 3 months, but I mean, well under average is a week. So if the patient is barely meeting guidelines of a week, I'm suspicious that that's probably not bipolar 1 because on average this is going to last 6 months untreated. And it really can last that long. I just had a patient and I think she was almost in a manic state for like 5 years because she's like, my whole life just changed 5 years ago. And kind of that's when these voices kind of started. And that's when I started feeling amazing and that I could do anything. And I started getting the messages from God. And so really that's kind of of more of what I see in terms of bipolar 1. The onset of depression is typically first. So bipolar 1, you will be depressed. Actually, most of the time is in depression, probably 80 to 90% of the time. And the suicide risk for bipolar 1 is actually even higher than major depressive disorder. Um, um, so because it's really these lows that are they're just deep lows, and sometimes they even just want the mania to bring them out of it. Um, so you typically have this depression in your early 20s, and then you have your first manic episode in the late 20s or early 30s. For women, it's a little later. For men, it's more like late 20s. For women, it's early 30s. And there are different courses. One of the courses for mania is kind of this relapsing remitting course where you get a manic episode and then you're okay, and then you get a manic episode and then you're okay. The thing is the more it's untreated, usually the periods between manic episodes will get shorter and the duration of the manic episodes will get longer. So they're just kind of getting worse and worse over time. So that's why treating this is important. And that really determines the prognosis, which is the third bullet point. So it is going to be a bad prognosis if it's untreated. But you can live a very normal life in between those episodes that are untreated. You're just going to have these very extreme behaviors in between the episodes. In general, this isn't really in textbooks, but just from kind of practical experience, at least I haven't seen it yet. These people with mania will either, or bipolar 1 will go to hospital or the jail just because their behaviors are so severe and impairing. So this isn't like I got mad and I threw ketchup at my boyfriend's car and then I was better. That's something different. Um, or I keyed everyone's car and then I felt better. That's different. These behaviors are persistent, they last a long time, they're severe and they're very impairing, and it's going to lead to hospitalization or jail. Here are other causes of mania. So if I took a lot of meth, I would feel pretty darn good. I'd feel euphoric. I would probably at some point hear the voice of God or someone else telling me that life is great or telling me to do things. Some medications, especially in the older population, will cause mania. Mania is a symptom of delirium, for example, or could be a symptom of dementia. So just because someone's manic doesn't mean it automatically points to bipolar 1. Just because someone has all of the dig fast and it's been going on for a week doesn't mean it's all due to bipolar 1. And that's the point of this slide. It can also be like seizures. Seizures can cause it as well. So what are we going to do about this? Um, I always feel kind of bad when I treat mania, especially if they're really nice and euphoric. They just feel amazing because I'm kind of bringing them back to reality. And then the risk, of course, is that they switch to depression. So not only am I bringing them back to reality, but I'm also switching them to a depressed stage, and that always makes me feel kind of bad about myself. But the journey has to end at some point. And mania is really bad for your brain. It's kind of actually burning out the brain. I didn't mention that, but it's neurotoxic. Um, so that's why the course untreated of mania, it gets worse and worse over time because you're burning more and more neurons. It's kind of like a fire that you have to try to control. And so it really is important, even if they're feeling great, to treat it. First, we haven't really covered, I realize now, we haven't covered treatment of anything. So we've gone over depression, we've gone over mania and bipolar 1, we've gone over the criteria for each, but we have not gone over how to treat either depression or to treat bipolar 1. So this is treatment. First, for depression, and we'll go over depression first, and then we'll go over bipolar 1. First, you want to treat early and aggressively. And this is shown from the STAR-D study, which is the largest study of our medications and how well the medications work. And we'll cover it in a second here. But you want to treat early and aggressively. You want therapy, especially for that atypical depression with the kind of chronic suicidality or just kind of chronically feeling low. Therapy is probably going to be much better than even the medications. And then a really big point that I definitely want you to know is that ECT is the gold standard for treatment-resistant depression. ECT is the gold standard. That means electroconvulsive therapy is the gold standard. And I think in our society, we should find this surprising because ECT is talked down on. And every time we try to say good things about ECT, the Scientologists come out of the woodwork and they'll pick at us and they'll create a bunch of false literature that says how bad ECT is, and then they'll also say how bad psychiatrists are because they hate psychiatrists because we're not we're really not great. So yeah, we're the worst. Um, Trying to get away from that, moving somewhere else here. Yeah, but ECT really is the best. Please don't listen to Scientologists. We'll see why that's the case in a second. So this is the STAR-D. This is the entire paper. I don't know why I put this up. Let me get rid of some of these boxes, kind of. There we go. I don't, initially 4,000 patients were enrolled. Maybe that's why I put this up. And it shows you the algorithm. They all started on this one SSRI. And then if that didn't work, then they moved to this level, bupropion, Zoloft, or sertraline, venlafaxine, or Effexor, or cognitive therapy. And if that failed, then they went to the next level. And basically, there's 4 levels in this study. The important thing is just to show how many people are enrolled, and then that you lose people at each level and your treatment becomes more ineffective, down to level 1, 2, 3, 4, 5, down to level 5. A kind of a more helpful slide is this one, and this shows the effectiveness of our antidepressants in a real world setting. Um, so you start with the Celexa, the citalopram, you get it up to max dose, and 1/3 of patients will then go into a cure. So if I start, and this is helpful in framing treatment expectations as well, and something that I tell all my patients is that if we can pick any SSRI, it doesn't really matter which one. And in general, for the average patient, 1/3 of them will get completely cured from that first SSRI, and 1/2 of them, or 50%, will just feel a little bit better. Well, that won't feel a little bit better. They'll feel 50% better. So that's pretty good. And that's, so I can get half of all my patients feeling pretty good and trusting me. The other half are like, you're a quack. I don't know what you're doing. I'm never going to get better after like a month. So that's why I have this conversation up front, because I don't want them to think that the medicine I'm giving them is going to cure everyone. It's going to do a good job for about half the patients. It's going to cure a third. And then we have to go to the next stage. Now look what happens to the numbers. At the next stage, I'm getting anywhere between 25 and 30% cure. So I had 33% on the first medication. If I switch, I'm now between 25 and 30% cure. This is still okay because I'm still making 30% of that 70% that were remaining better. So I'm taking that 70% and I'm making 30% better. Now, if that doesn't work, I'm left with only now anywhere between 16 and 25% better. And then look at level 4, anywhere between 7 and 14. So basically what this is saying, the theory is that the longer depression lasts, because really what's happening is a month is going by, and then we have another month, and then we have another month, and then we have another month. By the time we're trying these last things, we're dealing with more treatment-resistant depression. And part of that is just being in depression makes it more difficult to treat. I think that's part of it. And then another thing that's happening is we're probably finding we're probably finding, we're probably getting patients here, like we talked about, we don't really know what causes depression. Um, it could be due to dopamine, it could be due to norepinephrine, it could be due to serotonin. Well, if I start a serotonin agent, but their depression is due to dopamine, that's not going to be affected until I get to this medication down here, because this medication, tranylcypromine, affects dopamine, right? Bupropion does too, but not as well. Buspirone does too, but not as well. So it's kind of led by the fact too that we don't really know what depression is due to, because at the end of the day, we're saying depression, but it really could just be like we're really saying cough. It's, this gets into a whole other area that we really don't have time to talk about, and that is like, what are these things? What is depression? What is the construct of it? Is it a valid construct? I mean, at the end of the day, we have to say it is, but it's a difficult thing to figure out. And so I think that's another reason going on here is we're finding true treatment resistance down here, and that makes it difficult. So that's medications, and that's why getting on medications probably sooner rather than later is a good idea, and why it also can take a long time to treat. Those are the two things that I just want to emphasize. The next question is, what are your thoughts on ECT? And I think it was probably surprising to you when I said ECT is amazing, because most of us probably think of this. This is a picture from One Flew Over the Cuckoo's Nest of Jack Nicklaus, right? Not to be confused with Nicolas Cage. So, Jack Nicklaus or Jack Nicholson? Jack, one's a golfer now, right? Nicholson's a golfer. Anyways, the actor, Jack Nicklaus, not Nicolas Cage, not Nicholson. Oh, good grief. Getting ECT, and of course they use the most primitive. This is not what ECT looks like at all. We don't, I mean, no, we don't put a bicarb because we're not worried about your teeth fracturing. You don't convulse at all. You don't even move during ECT. We don't put the pads like literally cotton on your forehead. We want you to comb your hair before. And then really in this movie, he's a sociopath, and they were using the ECT for punishment. And we don't use it for punishment, surprisingly. Yeah, that's not therapeutic. When you punish someone by giving them electrical shock, we don't do that. Yeah, and I don't think we ever did that actually. In this movie we did, but we never did that. Um, so what is it really like? How safe is it? Is it like this? Are they strapping me against my will to a table? No. Are they putting a bite guard? No. It's done with an anesthesiologist in the room, and it's done like any other surgical procedure. It's very well tolerated. There's very few long-term effects, if any, for the majority of patients. The biggest effect that we have to talk to patients about is maybe this transient memory loss, which is this fourth bullet point. Um, and so, it's not the time if you're getting electroconvulsive therapy, it's not the time to get married. It's not the time to have a wedding because you might not remember it. You probably won't remember your wedding if you're getting electroconvulsive therapy during that time. It's not the time to study for an examination, the bar exam. It's not a good time to do that because you probably won't retain that information very well. But the other memory, like if you've been married for now 5 years or a year or even probably a month or two, that memory will stay intact because it's not preventing, it's not taking away memories. You just can't really build new memories while you're in this time. There's no absolute contraindications, which is an incredible thing to say. So there's basically no, I mean, no absolute contraindications. So if you just had a heart attack the next day, theoretically, I wouldn't give you ECT. I think that would be not, I'd be medically safe. But it would be a relative contraindication. You probably shouldn't have ECT, but it's not absolutely necessary. So you could have open heart surgery and the next day have ECT. There's no absolute contraindication, although I still advise against that. You could be pregnant and have ECT. It's very safe during pregnancy, probably even more safe than medications. That electricity is not getting to baby. It's not having any effects on baby. There's no muscle soreness since a muscle relaxant is used. I put muscle relaxant in quotes because it's not really a muscle relaxant per se. It is a muscle relaxant that you give to any surgical patient, which prevents your muscles from moving, which is why you need someone in any surgery, to control your breathing, an anesthesiologist, because you can't breathe on your own. So you need a doctor that's specifically there just to control your breathing. And that's why ECT is fairly safe. And the muscle relaxants they use are only going to stop your muscles from moving for like 5 or 10 minutes. So it's literally just during the procedure duration. Your muscles won't move while your brain is receiving an electrical impulse. And then after that, your muscles will be able to move. So literally, I mean, I wish I had a video of this. In the future, I'd like to attach a video, but literally you just go into there, they connect all the electrodes to your head. They hook up a blood pressure cuff on your leg. Um, and the reason why they do that is so that when the muscle relaxant goes in, there's no there's no of the muscle relaxant that goes to your leg because they prevent the blood from going to your foot, basically, so that then they can see what the electricity is doing on your brain and your foot, because your foot will shake just back and forth very gently. And so essentially, the person pushes a button, the psychiatrist is there, they push the button, nothing happens except for the foot starts flapping forward and backward for 10, 20 seconds, and then that's it. And then the procedure is done. And then the patient gets wheeled back out after about 5 minutes of breathing on their own after they reverse the muscle relaxant. And you do that 3 times a week for a couple weeks, and that's your induction of ECT. It's just as simple as that. How effective is it? 80% of depression. So if you come in severely depressed, you're not moving at all. You're not eating. You've lost 30 pounds. You're totally and completely catatonic. 4 out of 5 of those patients will be cured, not just doing better, will be cured by ECT. And this is incredible because these patients that are severely depressed like this, about 30+% of them are going to be dead from their depression, from not eating, if they didn't have access to ECT. When ECT was used, that number dropped to 0%. So that's how effective it is. It works for 50% of schizophrenics that are unable to respond to medications, 2/3 of manic patients, and then 80% of catatonic patients. These are the patients that aren't moving at all. And notice that unlike the STAR-D, where the STAR-D starts with 1/3 of patients responding to a medication, these are like really healthy. These are patients that are walking into your office. They're like, you know what, doc, I'm depressed. I'm just not doing that great. That's what the STAR-D is dealing with. And with those patients, you're getting 1/3 response. With these patients, you're getting 4 out of 5 responding to their depression, and these are people that like aren't moving. Now, you do want to do this sooner rather than later. The longer you wait, the less effective it's going to be. So we expect these numbers, though, to be higher for less serious forms of depression. And it would be nice, actually, if we could use this for less serious forms of depression. Um, but just because of stigma and everything, we don't. Another thing to just make note is ECT is often used in combination with medications. And typically, it's not a way to get off of medications. It's kind of a way to get those medications jump started. So some patients will come into ECT and they'll think, oh, I'm so happy to do this because I won't have to take medications ever again. That's not really true. It kind of gets the brain working or a reset almost of the brain, like rebooting your computer, right? So sometimes your computer gets so out of whack that you just need to restart everything. That's what ECT does. It restarts everything, but you still need some stuff in the background helping it out once it's restarted so that it doesn't go right back to being all jumbled, right? You still need like that antivirus software, so to speak, right? And that would be the medication in this case. How does ECT work? This is a slide that shows you exactly how it works. You use electricity, you hit the brain, and then the brain gets better. So that's me making a joke because we really don't know how ECT works. There's just electricity, the brain shuts down, it restarts, and now, I mean, there's a lot of theories on this, but at the end of the day, that's kind of what we're left with. It's cool. Treatment of mania. Oh, before ECT, just as an aside, this is kind of just a point of interest. Before we had electricity, because of course we didn't have electricity prior to like the 1900s, we would actually, or it's like medical doctors would put people in like comas, like they would use insulin to induce a seizure, and that seizure was actually curative. So there is some thought that seizures might be involved in this, and inducing a seizure might be involved in this, and people would do this with insulin. People would do this with a substance called camphor. So they would also do camphor-induced seizures. And fortunately now we have electricity, which is way safer than camphor, way safer than like insulin, and can be controlled. Control the charge, you can control the resistances at the skin, and it gets really fun and really cool with ECT. Treatment of mania. So same thing, we have medications, we have mood stabilizers like lithium or valproic acid, we have benzodiazepines like Ambien or lorazepam, and we have a class of medication called atypical antipsychotics like olanzapine or Zyprexa. Don't have to know all this, I'm just saying you have 3 classes of medications: mood stabilizers, benzodiazepines, atypical antipsychotics in general to help treat your mania. So I put this slide in because what I'm really good at is, and I got in a heated discussion with my wife before about what is application, because I'm so interested in theoretical concepts that sometimes I just forget what even application is, and I need someone to explain to me for an hour what application is, because I'm still on the theory of what is application and the philosophical question. So I'm trying to bring us from a place of actually being productive by not maybe thinking about the theory as much. Because we've talked a lot about theory, but we haven't talked about like, how can let's say I'm just feeling down. Let's say I'm feeling down. What can I do to help me feel better, right? Or maybe I feel like I do have depression. What are things I can do right now, right after this talk to feel better? And there's a whole bunch of things you can do. The most important thing that you can do is get a good night of sleep. And we're going to go over each of these in turn, but here's just a summary of each of those things. The most important thing you can do is sleep. The next most important thing you can do is exercise. The next most important thing after that is please don't drink. I hear from so many people, the only thing that helps me is my marijuana. Please don't do that. With every medication, if we're using marijuana as a medication, there's going to be a side effect. There's going to be a side effect from that medication. And the side effect, if you're using it for anxiety, is rebound anxiety. When you're off the marijuana, you're going to rebound, you're going to have more anxiety. So you get into this cycle of, I need my marijuana to feel relaxed. And when I'm withdrawing from my marijuana, I feel even more anxious. And I've just seen so many patients where I've just said simply, please stop the marijuana. They actually listen to me, they stop, and they've gotten better because they're in this cycle of treating their anxiety using something. And then by using that thing, their anxiety is actually getting worse. Of course, eating healthy, practicing mindfulness, being in the here and now, going out in nature, just taking a walk in nature is very helpful. Having an attitude of gratitude. Mr. Rogers has this video where he's talking to all the celebrities and he says, just for 1 minute, I want you to think of someone that's special in your life, someone that's impacted you, and I want you to be thankful for them. I'll watch the clock. You just take a minute right now and think of them. Very powerful stuff. Just having a thankful attitude in life can really cure a lot of ails. Participating in your community, right? So getting out there. When we're feeling down, we don't want to do this, but if we do it, it'll actually help our depression. Consider therapy and then take medication. So first, sleep. This is my firstborn when they were really young. They're two now. This is a nice, fancy hotel robe, and I just thought this is a great picture and a great reminder of how great sleep can be. Some of us do not think that sleep is this nice. It can be. There's actually therapy for that, and if you don't think sleep is this nice, I've recommended it now to a bunch of friends and family. It's a program called CBTI, Cognitive Behavioral Therapy Insomnia. None of my friends or family have done it, but it would be a great way to relieve their anxiety over sleep if they did. And if you're ever interested, you can reach out to me and I can direct you to any resources there. So you want at least 8 hours. If you sleep too much, that's bad. If you sleep too little, that's bad. Your room should be like a tomb. So you do nothing in that room. Sometimes this isn't practical because we're students, because we're busy and we just don't have any other space other than our room to work. But we really shouldn't be working right next to our bed. That's not a great idea. And it's not a great idea. I remember when I was taking my first board exam in psychiatry, not in psych, excuse me, in medicine, in med school, I did, all I was doing was studying like 80, 100 hours a week, right? That's all I was doing every single week. And I always did it right next to my bed. So of course, this is the most anxious, anxiety producing test I've ever taken. It requires the most time, and that's all I'm doing. So I spend all my time next to my bed, and then I get in my bed at night. How do I feel? I feel wired. I feel wired because I've been studying all day next to my bed. So and really that lasted after I finished my test until I actually moved. So I had to move, and only when I moved did my brain go, oh man, I can relax now in this place where I couldn't relax in that other room because that entire room was associated with this horrible test and this horrible like traumatic experience. So yeah, you sometimes, I mean, that in my case, that was the only thing that would help. But so these associations really do happen. No screens an hour prior to bed, the thing that definitely does not happen in our society. But we shouldn't have any screens, no cell phones in bed, um, none of that. You need a consistent bedtime routine. So, this is the time that I brush my teeth. This is the time that I read a little bit. This is the time that I have low lights. Maybe I light a candle. Maybe I use a diffuser, or I use or I smell, or, I put on some essential oils, or I put on some very relaxing music. And, you do that for like an hour, and it's just your unwind time. Regular wake up time, probably the most important. So if you wake up every single day of the week at 6 a.m., and I know this because my toddler wakes me up every single day at 6 a.m., you're going to go to bed every single day at 9 or 10 p.m. because you're going to be exhausted. It doesn't matter that you don't want to go to bed at 9 or 10 p.m. If you wake up every day at 6 a.m., you will go to bed at that time. But wait, I won't. Well, that's probably because you're sleeping in. So what a lot of us do, and what I know I've done in the past is, well, it's Friday night. I'm going to stay up till midnight, till 2, till 4. And then, of course, the next day, Saturday, I don't have work. So I'm going to sleep in till noon or 2 p.m. And so you say, I go to bed every single day at the same time and I wake up every single day at the same time. But do you do that on Saturday? Do you do that on Sunday? Do you do that on Friday night? And so that's where we kind of get out of sorts. Don't be afraid to leave the bed if you're not falling asleep. So we don't want to associate the bed with anything anxious. We want to be calm there. We want to be relaxed before we get in there. And this is really what causes that really negative thought cycle of I'm never going to fall asleep is you feel tired, you get in bed, and now you feel wired. That's because your brain has associated the bed with something other than sleep. Looking at the phone, doing work, that's when you need to take a step back, and it's going to be kind of more of a long-term fix with cognitive behavioral therapy. Um, but what you can do in the interim before you learn all those skills is you can just get up after 30 minutes and go to another room and do something relaxing. Exercise. Exercising, high intensity, meaning you're getting your heart rate over 100, at least 30 minutes a day is just as good as a full dose SSRI. I don't have that study here, but I could find it. And mild to moderate intensity of 1 hour a day is also just as good. So mild to moderate is, not getting your heart rate up to 100 beats a minute, but working out, walking for an hour a day, uh, gardening for an hour a day, doing something like that, an hour a day is just as good as high intensity of 30 minutes, getting your heart rate above 100 for 30 minutes a day. One second here. Okay. Remember, more is better than less, and some is better than none. So we can often get very discouraged when it comes to our exercise routines. We can think, I'm not doing enough. But every time I've gotten into that kind of funk, I just say, you know what? I haven't exercised in 2 months, but I want to do it today. And then all those thoughts come up. Well, what does it matter? You haven't exercised in a month. Well, you only have 5 minutes free. And then all the things come out as well. 5 minutes is better than 5 minutes is better than 0 minutes. 1 minute is better than 0 minutes. And so I would say that just try to do as much as you can with your time. There are times in our lives when we don't have time, and that's okay. We just still have to do some of these other things. One of the other things, of course, is no substances. Chronic alcohol use, and people don't realize how much substances can affect our mood. So let's say I drink 6 beers a day, and I always drink 6 beers a day, and then I stop because I'm like, you know what, I don't want to do this anymore. It just isn't for me. I can tell it's affecting me. When I stop, it can take up to 6 months, up to half a year, maybe even longer sometimes. This is on average again, for my mood to return to normal. And alcohol and caffeine are some of the biggest drugs. I include caffeine in there, a drug that I enjoy, caffeine, can lead to a bunch of anxiety. I mean, actually, at high levels, caffeine can even lead to like seizures and things like that. Others, of course, besides alcohol, alcohol can lead to psychosis, meaning you're completely detached to reality. It can definitely do that due to like vitamin deficiencies and the withdrawals from alcohol. And so, if it depends on um, what your relationship is with each of these substances, right? A little is okay in general. As a general principle for everything, a little bit is okay. Anything more than a little bit might be causing some problems. And that's going to vary depending on the individual. Eating healthy. So, cooking your meals at home, trying not to eat out, eating fruits and veggies, avoiding fad diets, and trying not to eat processed foods, right? So there's always a new fad that's trying to make us lose weight. And we'll do it for a couple weeks and we'll lose a lot of weight, or a month or 2 months, and then we'll start eating again, and then we'll be 5 pounds heavier than when we started. And we keep doing that, and then we keep gaining 5 pounds, 5 pounds, 5 pounds. So it's better just to try to eat consistently decent food. And there is certain types of therapy to change our relationship with food. There's something called Noom, Noom. It is a paid service, but it's a form of cognitive behavioral therapy that helps with diet and just how we think and feel about food. And that's one that I don't have a lot of experience, but I know other physicians have used it to good effect. Practice mindfulness daily. So mindfulness is basically just saying, I am here right now. What am I experiencing? So something I'm experiencing right now, I'm experiencing this table. My room is actually quite warm, so I'm experiencing the warmth of the room, kind of the uncomfortableness of that room now that I'm feeling it. Now I kind of keep feeling it. Um, so, we this entire time I've been talking to you, I actually haven't been aware of these bodily sensations, where I am, how my feet are positioned, how my hands are positioned, some of the stress in my neck or my lower back. And just being intentional throughout the day, checking in with yourself, saying, how do I feel about this is very powerful, very effective. There's a lot of study out of UCLA on mindfulness. I think they even have maybe a whole institute on it. And so if you just Google UCLA mindfulness, there's a whole bunch of research on this, and there's even apps out there, mindfulness apps, and it's very good. Go out into nature. This is one of my favorite places to go. This is the Huntington Library. Um, this is also the bridge, I think, in the scene in Iron Man 3, where they digitally, I think they removed the water and they just kind of fought in this area or in front of it or something. And I think it's Iron Man 3. But anyways, that's neither here nor there. This is the Huntington Library, an amazing garden. And literally, if I'm feeling bad and I walk here, or I drive here because it's in Pasadena, and I walk around, I mean, I just feel a bunch better. Attitude of gratitude, and this is evidence-based. There are studies to support this as well. Have an attitude of gratitude. Just being thankful is something that goes a long way. Participate in community. This is my community. No, it's not. This is not my community. This is from that show Community. Very nice people. My community looks like, no, it doesn't look like it. But this is a community, and if you're in a funk, reaching out, touching base with someone that you know or care about. Don't listen to the voice that says there's absolutely no one in your life that you can reach out to. There's always someone in your life that you can reach out to. Consider therapy. This is really a really great meme that I like. It says, the sick part is, the pinata says to the therapist, the sick part is, I kind of like it when they hit me. Um, yeah, so if that's the way you feel, you might want to consider therapy. Therapy is very good. There's all different types of therapy. People get very heated on which one is the best. I don't really think there's necessarily anyone that's the best. I think they're all good. I think they all work through the same way, pretty much. And it can be very helpful just to basically share with another human being what you're going through and to actually have that human listen to you. Sometimes our loved ones don't have as much time to listen to us as we would like, and sometimes you need to talk to a trained expert who literally they're trained to listen to you, trained to make you think more about your experience in your life, and that can be very quite helpful. Take medication. This picture I tried to make as natural as possible because I think there's something in our society that says medications aren't natural, but you know what is? Marijuana. Well, what I have to tell you is that medications are just as natural as marijuana is. And the thing that I like is um, I know the side effects of the medication. I also know the side effects of marijuana. And let me tell you, in general, the side effects of marijuana are worse than medications. So in SSRI, I know exactly what's in it pretty much, right? And that's what I've done now for a living, and in my specialty training. I've been looking at this for 4 years. So, and I will be for longer. And the people that I read have been looking at it for decades. And something like Prozac has been out since the 90s. And all medicine cares about in general is making sure that no harm is done. And so, are there, quote, natural substances oh, like lavender oil for anxiety? Yes, and actually, lavender oil works amazing. It's something for anxiety that I actually recommend to a lot of my patients. It's called Silexant, Silexant. Actually really good, better than some of the kind of traditional medication. Is there St. John's wort for depression? Yes, but St. John's wort, it has a lot of interactions in my liver. It has a lot of interactions with like grapefruit juice and other medications, and it's difficult to dose. And a lot of the times with these herbal medications that you buy, the dosing guidelines, or you don't really know. There's not someone that quality controls that says, yes, there are 80 milligrams of lavender oil in this. Um, it says 80 milligrams, but there could be 70, there could be 100, there could be 10. There's no real quality control for this. There are some organizations, but in general, there's no quality control. So the only things that are quality controlled, unfortunately, are pharmaceutical medications. I wish that these other substances were quality controlled because there are good options, but unfortunately, they're not. Takeaways, so just to kind of wrap up our talk, there's the science of mood. There's practical, which is our first part, the majority. We just talked about depression, we talked about mania, we talked about how to define those, we talked about how to treat them, what causes them. And then the second part, we talked about practical ways to improve your mood if you're feeling down. All of these really methods we would talk about could help center you also if you're feeling elevated in your mood. Sometimes feeling elevated is a way to um, get by the hardships in life. If all I feel is that life is amazing, then I can't really confront the hardships. And so when we're elevated, going on a walk and thinking about the hardships while we're in a nice place that's safe can also be very helpful. If there's any questions, feel free to reach out to me. And thank you so much for your time and your attention.